Welcome to the Assembly Committee on Health and Human Services. Would the Secretary please call the roll?
Assemblywoman Gonzalez. Here. Assemblywoman Gorlow. Here. Assemblyman Gray. Here. Assemblyman Hafen. Here. Assemblyman Hibbets. Here. Assemblyman Koenig. Here. Assemblywoman Newby. Here. Assemblyman Wynn. Here. Assemblyman Orentlicker. Assemblywoman Taylor. Assemblywoman Thomas. Chair Peters.
I am here. Please mark Assemblywoman Taylor and Assemblyman Orentlicker as present when they arrive. Welcome all. There she is. Thank you so much for joining us here in person. It's great to see everybody. It's been a minute since we've all been together. It's wonderful to have you all here. A couple of housekeeping announcements. Please make sure that all of your devices are muted so we're not interrupting folks in the middle of their presentations. Members of the public may provide testimony in a variety of ways, all of which are listed on the agenda. You may also submit public comment in writing in addition to testifying or in lieu thereof. Written public comment may be submitted before, during, or up to 24 hours after the meeting's adjournment. If you wish to testify in person, please sign in by the doors and leave a business card with your name. If you do not testify, you may wish to sign in as well, so we have a record of those who are interested in a particular bill in the event that we'd like to get a hold of you. To ensure an orderly flow of discussion, all comments, questions, and responses must go through me. Also, committee members must be recognized by me before you can speak. If you are presenting via Zoom, please leave your cameras off and microphones muted until it's your turn to present or I have directed any questions to you. When testifying in person, please turn the microphone on to speak and off to listen so that we do not get that reverb between our Las Vegas center and here. With that, we'll move on to our agenda. We have two bill hearings today, both Senate bills, our first Senate bills. And we will take these in order today, starting with Senate Bill 42. So Senate Bill 42 revises provisions related to the funding of medical assistance to indigent persons. We welcome Ms. Jacobs. Please remember to state your name for the record. You may begin when you're ready.
Thank you, Chair Peters and members of the committee. I'm very glad to be here this afternoon before you. Joanna Jacob, JACOB. I'm the Government Affairs Manager for Clark County. I'm here to present Senate Bill 42. Senate Bill 42 really will allow Clark County additional flexibility to spend indigent care dollars to supplement payment programs that serve to help us finance UMC of Southern Nevada, our public hospital in Southern Nevada. These dollars, just to explain, as we look at this bill, these supplemental payment programs, Clark County, and the reason why Clark County is presenting this is because we pay the non-federal share, a state match, for Medicaid for these supplemental payment programs. These are for services that UMC provides to Medicaid and uninsured patients. It operates, I know that you have heard bills here before about the provider fee. This operates very similarly, that Clark County puts money in that is matched at the federal level, and then it operates to reimburse UMC over and above their regular Medicaid reimbursement for a Medicaid enrollee. And so going to the bill, I want to direct you to Section 1. Really, this is where we're making the change. We have the authority under NRS 428-295 to direct indigent care dollars to an upper payment limit program established by Medicaid. There are two in the state of Nevada that the Medicaid has approved, both for inpatient services and outpatient services at UMC. So 10 cents of every $100 of your property tax in Clark County goes to fund this indigent care, and then we use those funding to supplement, or to use that funding is directed to these supplemental payment programs. There are also other ones that Clark County funds, but you can see here that we are authorized under the statute to fund the upper payment limit program. And what that program does is brings the Medicaid fee-for-service rate closer to what Medicare would pay. So it pays up to the upper payment limit of what Medicare would reimburse for a particular service. So again, we have an inpatient and outpatient program. What we're asking here in Section 1, subsection 3, is for additional authority to take advantage of some of the other supplemental payment programs that have been announced with the advent of the Affordable Care Act, and as CMS is unrolling various value-based programs and other supplemental payment programs, we are looking always to try and maximize our dollar so that we can continue to fund UMC. So you can see here that we are asking for authority to contribute to any program authorized under any other supplemental payment program administered by CMS, which would provide an enhanced rate of reimbursement to any public hospital located in the county for the hospital care provided to Medicaid recipients, or to make supplemental payments to the hospital. And really what we're trying to get after there, this was amended once in the Senate, and the reason why it was amended is to add the language administered by CMS. Clark County and UMC have been working on something called a Medicaid Directed Payment Program, which is approved by CMS through something outside of the state plan, and it operates sort of to get hospitals a higher rate of reimbursement, or to enter into value-based reimbursement programs that has been really tried to be promoted by the Affordable Care Act, and we are working with the state Medicaid program on that. So we have a Medicaid directed payment program. It actually operates to have the managed care companies direct value-based reimbursement programs if we meet certain objectives, and that is something that we are looking to do so that we can contribute this funding to take advantage of that funding arrangement that will benefit ultimately UMC. I wanted to talk a little bit about the indigent care dollars. Really, this is the indigent caseload at UMC, why we use this funding is generally our indigent caseload is about 48.9% when we checked at the beginning of this session for the patients at UMC in our total patient mix. And we are really largely serving Medicaid patients at 43.9% of that 48.9. The remaining 5% are self-pay, which there is no other form of insurance. So that's really the genesis of this bill. I did want to put something on the record because we got some questions in the Senate about this. This is one source of funding. There is also something known, if you have been on the healthcare committee before or you sit at IFC, you may have heard about something called the Indigent Accident Fund through the years. This is a separate source of funding for hospitals. There was a question about whether this bill would impact that source of funding. It does not. The Indigent Accident Fund is under 428.206. It's a separate source of funding that is funded by 1.5 cents on every $100 of valuation. So that fund actually operates to help hospitals get reimbursed for uncompensated care if there is uncompensated care. So we're leaving that funding is intact. This one is actually meant for taking advantage of other supplemental payment programs. That's it. I know it's probably, these are very complicated arrangements. I can definitely stand for questions. I will note this bill passed out of the Senate unanimously. We were very happy to have their support, and I look forward to any questions that you may have. And that concludes my presentation.
Thank you, Ms. Jacobs. We have several questions. We'll go ahead and start with Assemblywoman Thomas, please.
Good afternoon, and thank you, Madam Chair. And thank you for the presentation. And I understand that this passed out of the Senate unanimously, but I do have a question. And that question has to do with, you kept referring to UMC. So what prevents Wausau from also, they have no indigent here in?
Thank you for the question. Through you, Chair Peters, to Assemblywoman Thomas, Joanna Jacob,
Please
for the
feel
record.
free to go directly.
Okay. This is actually, thank you for that question and a point of clarification. This statute does apply to both Clark and Wausau, but actually, if you look at it, it's really dedicated for public hospitals, and that is, so Clark County has entered into that arrangement for UMC because it is a public hospital. Nothing prohibits Washoe County from doing this if they wanted to support a hospital, but it is, because we are the public hospital in Southern Nevada, that is a longstanding arrangement that we've had with UMC and with the state of Nevada to try and take advantage of these supplemental payment programs to fund that indigent care. Thank you.
So just my understanding, I want just clarification. UMC is the only public hospital in the state of Nevada.
Joanna Jacob, for the record, yes, that's correct.
Thank you.
Thank you for the questions. Assemblywoman Taylor, I have you next.
Thank you, Madam Chair, and thank you, Ms. Jacobs, for the bill, and congratulations on unanimous
Thank you.
passage out of, or the other side, as I like to call them.
The other side.
Two questions, if I may, Chair, but the first one may do them both. Just confirm the source of the funding. I know you talked about the supplemental pool for the indigent care, and I know it says that there's money that comes from it comes from the general fund for the county. Can you just clear that up for me a little bit? I didn't follow it. Maybe I need more coffee, and I probably do.
Thank you for the question, Joanna Jacob, for the record, and to you, Assemblyman Taylor, not through the chair. I definitely need more coffee too, so please have a sip and I'll try and explain. This is, if you look further up in the statute, the source of the funding is in NRS 428-285, so it's actually your property tax valuation. It's talking about property tax in this case. If you look on your property tax bill, you will see a breakout, and you'll see often a breakout for indigent care. The funding in this, I'm trying to remember the statute, it says a minimum of 1 cent, and then we can go up to, the Board of County Commissioners can go up to, through ordinance, 10 cents per each $100 evaluation of your property tax in our jurisdiction. So that's the source of the funding. We have gone up to 10 cents, and so that's the funds that we use for indigent care in Clark County.
Thank you, Chair. Yeah, so when the county goes up, and I'm sure I've seen that at some point, but mostly I pay my taxes through my mortgage, so I don't get to see that too often, or I don't dig enough to see it too often. But in that, so does the county have to go back out to raise property taxes, or is it just from the property taxes that are already allocated towards the county?
Thank you for the question, Joanna Jacob. For the record, this is from existing property tax. So this is just how your property tax today is divided up and what it funds in the counties. A portion of it, the 10 cents per every $100 of valuation that we collect, is devoted to this indigent care. So we are not raising taxes. This is from existing revenue, and this has been something that we've been doing for many years for the upper payment limit program that we've had in place at UMC, and then we're looking to see if we can take advantage of some of the other newer payment programs.
And may I have my second question, please, if I may, Madam Chair? Thank you. So then to that, you mentioned other opportunities, other payment programs. Is that like some federal match monies?
Thank you for the question, Joanna Jacob, for the record. Yes, exactly. It does operate like federal match, or I like to think of it as sort of like the provider fee that has been discussed in this committee, and that you're putting some money into, you're putting a pot of money into this program, and you're saying, like the program that I decided was a directed payment program. It basically, you have to apply, and we've been working on setting up an application, and UMC says, okay, we're going to hit these various value-based metrics. We're going to improve the directed payment program that we're currently working on with the state, says we're going to hit certain quality metrics that are going to improve access to care. And so then CMS has things that say, well, we'll reimburse you if you meet these metrics at a higher rate, and we can make a showing to say if we do this, that we'll get a higher rate of return that comes back and administered through the federal CMS. So it is like a federal match. It operates these programs. The upper payment limit I mentioned that we do pays us more in that we have fee-for-service Medicaid, that if it's usually long-term care, disabled, and we can say under the upper payment program that we can bring that reimbursement up to Medicare, so we get extra there. And so it's increased federal match, yes, and then through the directed payment program, if we meet those metrics, we can see a rate of return that is in addition to just the regular Medicaid billing rate. And so it is bringing more federal dollars to the state, and it's devoted to increasing and maintaining access to care.
Thank you so much. Thank you, Ms. Jacob, and thank you for bringing the bill. I mean, it seems like what it will really do is give, as you just said, more access to care for those who are indigent, those who need it. So thank you for bringing the bill, and thank you for your indulgence, Chair.
Thank you for the questions. We have another set of questions from Assemblyman Hafen.
Thank you, Madam Chair. And Assemblywoman Taylor actually stole my question on how these funds were going to be used. So thank you for addressing that. And that does alleviate my concern on the state being on the hook for this. I do have some concerns that have been brought up in other committee hearings related to UMC's hiring practices. And so I want to be able to be ensured that these monies are going to be properly used to really help the people that it needs to help, and not some of these practices that have been questionable, that have been mentioned in our other hearings. And so I have some concerns there just based on what we've had in other hearings, and I'm not seeing safeguards in here that help me alleviate those concerns. And so maybe you could, Ms. Jacobs, help me understand that this is really going to go to the people that need this assistance, and it's going to do the good, because I think the intent is there, and I absolutely agree that we need to do this, but I do have some reservations with some of the current practices at UMC.
Thank you, Assemblyman Hafen. Joanna Jacob for the record. I think I look at it like this. The upper payment limit that's in the existing law today is directed towards services that are rendered at UMC. Ultimately, and I guess I'll go back. Before I was at the county and before the passage of the Affordable Care Act, the county has always funded UMC. There was a significant concern for many years that they were operating in the red, and we want to make sure that those doors stay open, because as we noted, they are the public hospital serving our community. I think the safeguard that you have is really through the state of Nevada and their Medicaid. These are contractual. These are contracts designed for services at UMC. So, for example, for the indigent care, the upper payment limit, it is an intergovernmental transfer. So we partner with the state, and it's defined by contract, and that goes to the Board of Examiners. So that is reviewed by both our Board of County Commissioners and the Board of Examiners for approval of those intergovernmental transfers of funding from Clark County to the state. And that this other program that we're talking about, the directed payment program, is really enhancing reimbursement rates to the services that we've already rendered to patients in the hospital. And I think that's really what we're designed to do. Ultimately, we want to make sure that UMC continues to be funded and that we can continue delivering the services that we provide at UMC.
Thank you. I have one last question on my list from Assemblywoman Newby, but please let me know if I missed you.
Thank you, Madam Chairwoman, and thank you for the bill. I was wondering about the indigent care tax, the 10 cents. Does that all go towards the medical care? I recall there used to be some portion that was for financial support for indigent individuals through social service. Is that a different tax?
Joanna Jacob for the record. This is actually throughout NRS 428. So yes, there is separate funding in a different chapter. I can't remember which one it is for supporting indigent care as well. This source of funding, the 10 cents that I'm referring to, does support also long-term care, which in our community, the Clark County, just for the committee's edification, Clark County pays the non-federal share. So instead of the state paying, we pay some of the match for Medicaid for long-term care. So a portion of this also does go, and we divide it up a number of ways as we administer these supplemental payment programs. Long-term care that goes to support the community and the hospital system as a whole as well. So that is a separate source of funding. And like I mentioned, the indigent care for hospitals is a separate source of funding, and it is throughout NRS 428. I'd be happy to provide the breakout for you after the hearing, if you'd like.
Thank you. Are there any other questions from the committee? Seeing none, we'll move into testimony. Thank you, Ms. Jacobs. We'll go ahead and take support testimony first. We'll start here in Carson City and then move to Las Vegas and then the phones. Is there anybody in Carson City who'd like to provide support testimony on Senate Bill 42? Seeing none and seeing no one come up to the table in Las Vegas, BPS, would you check the public line for support testimony on Senate Bill 42?
Chair, there are no callers to testify at this time.
Thank you. We'll move us into opposition testimony here in Carson City and Las Vegas. Is there anyone to provide opposition testimony? Seeing none in Carson City and none in Las Vegas, we'll move to the phones. BPS, is there anyone on the public line for opposition testimony on Senate Bill 42?
Chair, there are no callers at this time.
We'll move us into neutral testimony. Anybody in Carson City or Las Vegas who'd like to provide neutral testimony? Seeing none, I'd ask BPS to check the public lines for neutral testimony on Senate Bill 42.
Chair, there are no callers to testify at this time.
Thank you so much. We're waiving our last remarks. That brings us to the end of the bill hearing on Senate Bill 42. Thank you so much, Ms. Jacobs. All right, we'll move into the bill hearing for Senate Bill 44. Welcome, Ms. Peak. Please remember to state your name for the record. You may begin when you're ready. And I apologize. Senate Bill 44 revises provisions related to dental and oral health care.
Chair Peters and members of the Assembly Committee on Health and Human Services, I want to thank you for the opportunity to present today on Senate Bill 44 on your first day of hearing Senate bills, so thank you for that. My name is Julia Peak, and I serve as one of the Deputy Administrators for the Division of Public and Behavioral Health. I will provide a brief overview of Senate Bill 44 and then happy to answer any questions that you may have. As background, I wanted to remind the members that the Division of Public and Behavioral Health was directed through a letter of intent in 2019 to secure sustainable funding and diversification for the oral health program, and specifically the salaries of the state dental health officer and the state public health dental hygienist. This bill helps ensure we can keep that commitment, and I've provided copies of that letter of intent as well as an exhibit. SB 44 is a bill designed to improve the hiring and retention of our state dental health officer and state public health dental hygienist, as well as to streamline the management of the Nevada Oral Health Program. If passed, this bill would take effect on July 1st, 2023. To walk through this bill in Section 102, we request changes to allow the director to appoint the state dental health officer and state public health dental hygienist. We also request that the references to division be replaced with department. Please note that we request that the residency requirements remain and that the appointment of both positions will be based on education, training, and experience. We would like the licensure requirements to be permissive for both positions to allow greater flexibility to recruit and retain people in the positions. This will mimic the current requirements of our chief medical officer at DPBH in the position, and they must have certain education with permissive language for the licensure as well. For both positions, we request the removal of the language that requires the positions to devote all their time to the office and limit any ability to hold another business or vocation outside of the role for profit. We have been challenged to recruit these positions based on salary, and we have to support them. Removal of this language will allow the individual to continue to work outside of the time devoted to this role. This is even more important for our state public health dental hygienist because we're only able to support this position part-time. Within sections 3 and 4, we request the removal again of division for department, and that relates to the oversight of the advisory committee for oral health. We request that the director, not the division administrator, appoint the members of the advisory committee and also submit the report. Within sections 5 and 6, we again would like to replace division with department and administrator with director as it relates to the administration of the oral health program more broadly. Section 7 and 8 outline the role of the legislative council and department or agency for updating language accordingly in NRS and NAC. And that provides a summary of the bill. I'm happy to answer questions if you have any.
Thank you, Ms. Peak. There's a reason why we go through housekeeping every time. Sorry for the interruption. We have a couple of questions. Thank you for the brief presentation. We have a couple questions. I have Assemblyman Nguyen first.
Hi, thank you, Chair. Thank you. Good to see you again. I just wanted to see, I was reading it and I didn't see it changes in the amendment, and I apologize if I missed it during your presentation. The dental hygienist did not require to hold an active license. Is there a reasoning behind that?
Yeah, Julia Peak for the record, Division of Public and Behavioral Health. So as it's written now in statute, both positions are required to hold licensure, and the way that we're going to have it now is permissive. The only change we made through amendment is that for the state dental health director, so the dentist, that they must meet the educational requirements for licensure. If it's helpful, I can read to you the requirements of licensure if you have any questions about that. But it is permissive for both. We just specify they have to have the education for the dentist.
Follow up, Chair? I just want to make sure that as we create positions that direct, I guess, the industry and the health sector, that we, in my opinion, would be better served if they are actively licensed so that they can be understanding of all of the CE that's required, all of the changes that's happening in the industry. Because as you know, with technology and innovation, whether it's oral or preventative or any types of health, as things are moving fast, for a state officer that really direct direction. I don't think that works, but you all got me on there. That they should be actively licensed, so when they make a policy recommendation, they would understand the same pain, I guess, that these their fellow licensees would be able to. They can feel the pain and figure out how to mitigate it or how to kind of make it better. So I think that's just my suggestion. Even though the language is permissive, I would encourage that somehow we put that it is a active license so that we can focus on efficiency and innovation in how we direct our state initiative.
Julia Peak for the record. I'll just say that when we do recruitment, we could certainly put that as you get additional points or greater oversight maybe by the agency with that. I'll note that the AC4OH, which is the Advisory Committee on Oral Health, they also actively advise the two positions on what's going on, and they have a lot of dentists and dental hygienists that come and present to that committee. These positions will still be required to be very active and get work with the Board of Dental Examiners on CEs, on training, et cetera. I'll just say it's been incredibly difficult to recruit based on how the statute's currently written. The dental hygienist position was vacant for 6 months. The dental health officer was vacant for 15 months. So as written right now, it's very difficult to recruit. However, we can always put additional qualifiers on and give them, like I said, extra points during the application process. But limiting us by what's in NRS has just been extremely difficult to find somebody who would take the position.
Perfect. Thank you for that. Thank you, Chair.
Thank you for the question, and I'm kind of along the same lines. Are there other similar positions in the state where they're required to have active licenses or not? I don't know if you have that information in front of you.
Perfect. Here, yeah. So the other clinical position that we have is the chief medical officer, and that one was revised. I could give you that exact information. So that is found in NRS 439.085, chief medical officer. That is, again, the highest position within our agency. That was switched to may have licensure, again, permissive, but they have to be a physician or administrative physician who has a master's degree, again, focusing on the education, not necessarily the licensure and practicing in real time. That's the position that's really clinical in our agency that we reference. If a clinician is offering direct care in the agency, they obviously would be licensed. They're providing direct care, but these are administrative type positions.
Thank you for that. I was thinking that we had other areas where it wasn't really feasible to have an active license because your full-time job is really doing the administration work. I have another question from Assemblywoman Taylor.
Thank you, Madam Chair, and thank you, Ms. Peak, for being here and for bringing this forward. You mentioned that there's some changes that you're recommending, being recommended, I think, by the board, and that it makes it hard to recruit. And we know how hard it is right now, just about everybody to recruit, right? How does this align with other states for their, state directors in similar positions?
Yeah, Julia Peak, for the record, so we do have a report, and I'll quote some of it. It's the 2022 Synopsis of State Dental Public Health Programs. I can provide it as an exhibit. It's a great report to go over, and that's by the Association of State and Territorial Dental Health Directors. And so they really outline what type of clinician they have. I don't know if they specifically talk to licensure requirements, but we can certainly reach out to them and see if it was a question included in their survey. If it's helpful, 43 states, so 84%, actually have a full-time dental director. Again, doesn't specify necessarily the type of licensure, if it's required, and or the type of education that's required, but I can certainly go back and ask and see if they have that and follow up with the committee chair.
Would that be okay, Chair? Yeah, that would. Well, thank you, Ms. Peak. I appreciate it. Thank you so much.
All right, any other questions from the committee before we move into testimony? Seeing none, thank you, Ms. Peak. We'll go ahead and move into support testimony in our physical locations and then go to the phones. Is there anyone in Carson City or Las Vegas who would like to provide support testimony on Senate Bill 44? Seeing none, I'd ask BPS to check the public line for support testimony on Senate Bill 44.
Chair, there are no callers to testify at this time.
Thank you for that. We'll move into opposition testimony. Is there anyone in opposition in Carson City or Las Vegas who'd like to provide testimony today? Seeing none, BPS, is there anyone on the public line for opposition testimony on Senate Bill 44?
Chair, there are no callers at this time.
Thank you. We'll move into neutral testimony. Is there anyone in Carson City or Las Vegas who'd like to provide neutral testimony on Senate Bill 44? Seeing no one in Carson and no one in Las Vegas, BPS, will you check the public line for neutral testimony on Senate Bill 44?
Chair, there are no callers to testify at this time.
Thank you so much. I would ask if Ms. Peak has closing remarks. She has none, so we'll go ahead and close the hearing on Senate Bill 44. Thank you so much for your time today and for the bill. That being our last hearing today, we will close our hearings and move into public comment, which is our last item on the agenda today. We'll start here in Carson City and move to Las Vegas and then the phones. We do ask that we limit public testimony to 2 minutes apiece so that we have an equal opportunity to participate from the public. If there's anyone in Carson City, please come up to the table, or in Las Vegas. Seeing no one in Carson City and no one in Las Vegas, I'd ask BPS to go to the phones for public comment today.
Chair, the public line is open and working, but there are no callers at this time.
Thank you so much. That closes public comment for today. We do have a bill hearing scheduled for Wednesday, so I will see you all then. With that, we are adjourned.